Hello friends, today we will learn about nitric oxide and vasoactive peptide signal molecules. Myself Dr. Tejas Kakkar from Gujarat Adani Institute of Medical Sciences, Bhuj. Nitric oxide is one of the oxides of nitrogen. It is nothing but the free radical with unpaired electron. It is the smallest endogenous signal molecule and only one which is in gas form at normal temperature. Let's check history of nitric oxide in brief. Furchgott and Zwaski in 1980 demonstrated that acetylcholine caused vascular smooth muscle relaxation through release of endothelium derived relaxing factor. But Farid Murad in 1977 had already shown that glyceryl trinitrate caused vasodilatation through release of nitric oxide. And later on in 1987, Ignarro confirmed that EDRF was nothing but the nitric oxide itself. And because of this discovery, Furchgott, Ignarro and Murad got Nobel Prize in 1998, which denotes the importance of role of nitric oxide in our body. Nitric oxide is now an established key messenger in cardiovascular system, nervous system and in inflammatory cells. Nitric oxide is synthesized in cells from amino acid L-arginine with the help of enzyme nitric oxide synthase using molecular oxygen and NADPH, that is reduced form of nicotinamide adenine dinucleotide phosphate. This nitric oxide synthase enzyme has three isoforms, namely neuronal, inducible and endothelial, out of which neuronal and endothelial isoforms are constitutive and calcium calmodulin dependent for their activation, while the inducible isoform, as the name suggests, can be induced by inflammatory cytokines and is directly active. After synthesis, nitric oxide rapidly reacts with oxygen to form nitrites and with hemoglobin to form nitrates, which are excreted in urine. With great interest, nitric oxide also reacts with superoxide to produce peroxynitrite, which has cytotoxic effects. Coming to actions of nitric oxide. The main action of nitric oxide is in vascular system. It is a potent vasodilator. After synthesized in endothelial cell by endothelial nitric oxide synthase, nitric oxide is diffused to smooth muscle cell and activates soluble guanylyl cyclase, which increases concentration of cyclic guanosine monophosphate, and cyclic GMP activates protein kinase G. Protein kinase G dephosphorylates or inactivates myosin light chain kinase, resulting in vascular smooth muscle relaxation. Protein kinase G also decreases availability of calcium in smooth muscle cell by inhibiting membrane calcium channels. So, calcium binding with calmodulin is decreased, further potentiating relaxation. So, it is evidenced that deficient nitric oxide production plays a role in development of hypertension. Like in vascular smooth muscle, nitric oxide also increases cyclic GMP in platelets. This decreases platelet aggregation and thereby thrombus formation. Nitric oxide is also having anti-atherogenic action by suppressing adhesion of leukocytes to endothelium and cellular proliferation migration. So nitric oxide has protective effect on plaque formation. Hence, we can say that defective nitric oxide synthesis can cause increased thrombus formation and increased atherosclerosis. The role of nitric oxide in infection and inflammation. Inducible nitric oxide synthase is induced by cytokines in macrophages. Synthesized nitric oxide reacts with superoxide to produce peroxynitrate, which releases free radicals having broad antimicrobial action. Thus, nitric oxide helps to tackle with infection in the body. Nitric oxide is also having pro-inflammatory actions, including vasodilatation, increased vascular permeability, and stimulation of prostaglandin synthesis. Increased inducible nitric oxide synthase and nitric oxide levels are found in chronic inflammations like bronchial asthma, inflammatory bowel disease, etc. The interesting thing is that excessive nitric oxide synthesis may cause severe hypotension and septic shock, which induces inos in inflammatory cells, further increasing nitric oxide synthesis and sustained hypotension. In nervous system, nitric oxide works as neurotransmitter or neuromodulator in central nervous system as well as peripheral nervous system. For example, in CNS excitatory glutamate neurons, the N-methyl D-aspartate type of glutamate receptors activation increases nitric oxide release, which is involved in certain CNS functions like increased cerebral blood flow, learning and memory, and even nociception, means perception of pain and other noxious stimuli. In non-adrenergic, non-cholinergic neurons, there is now established role of nitric oxide in penile erection, and that is why sildenafil, a phosphodiesterase 5 inhibitor which increases cyclic GMP like nitric oxide, is drug of choice in treatment of erectile dysfunction. Nitric oxide also facilitates gastric emptying by relaxing pyloric sphincter, and in pyloric stenosis there may be defective nitric oxide function. Both neuronal as well as endothelial nitric oxide synthase are expressed in nervous system, and unlike other neurotransmitters, there are no stores of nitric oxide, but it is synthesized on demand and released by diffusion and not by exocytosis. Decreased nitric oxide synthesis may be involved in certain degenerative neurological diseases like Huntington's disease. Nitric oxide in pulmonary system regulates pulmonary vascular resistance and decreases pulmonary artery pressure. And defective nitric oxide function may lead to pulmonary artery hypertension. So again, sildenafil, a phosphodiesterase 5 inhibitor, is the drug of choice for treatment of pulmonary artery hypertension, as it increases cyclic GMP by preventing its degradation. So vasodilatation occurs and reduction in pulmonary artery pressure. And inhaled nitric oxide gas is the first line therapy in newborns with severe respiratory distress and raised pulmonary artery pressure. Nitric oxide donors. These are the compounds which contain nitric oxide in their chemical structure, and this nitric oxide is released enzymatically in the body. The examples of therapeutically useful nitric oxide donors, which are also known as nitrodilators, are organic nitrates like glyceryl trinitrate, organic nitrites like amyl nitrite, and sodium nitroprusside. In case of glyceryl trinitrate, nitric oxide is released by aldehyde dehydrogenase enzyme, which is abundant in veins. Hence, glyceryl trinitrate is mainly a venodilator used as anti-anginal drug. However, when GTN or other nitrates are administered continuously, rapid and reversible tolerance is developed to their venodilator action because of the reactive oxygen species generated during metabolism of organic nitrates inhibit mitochondrial aldehyde dehydrogenase enzyme, which is involved in nitric oxide release. Because of this reason, to avoid nitrate tolerance, daily 6 to 8 hours of nitrate free interval is advised to a patient taking long term nitrate, say for prevention of angina. Now, an interesting disease is associated with nitrate tolerance called as Monday disease. So let's understand what is Monday disease. Continuous exposure to nitrates can occur to workers of chemical industry, especially where explosives are manufactured. So when their workplace is contaminated with volatile organic nitrates, these workers find that upon starting day of work week, usually Monday, they suffer from headache and dizziness, which are the side effects of nitrates, called as Monday disease. Then, after a day or so, these symptoms disappear because of tolerance due to continuous exposure to nitrates. Over weekend days, as there is no exposure to nitrates, tolerance overcomes, and again on Monday, the symptoms reappear due to re-exposure. This is the reason behind Monday disease. Interestingly, these workers are protected from anginal attack in week starting days because of nitrates exposure, while they might develop angina in the weekends due to non-exposure to nitrates. GTN and other nitrates don't have antiplatelet effect because platelets have no enzyme to release nitric oxide from nitrates. Amyl nitrite is an organic nitrite which was used by inhalation for angina. It can dilate both veins and arteries, but the enzymatic mechanism to release nitric oxide is unknown. Sodium nitroprusside, administered by intravenous infusion, it dilates both arterioles as well as veins through nitric oxide plus directly activating guanylyl cyclase. The release of nitric oxide is both enzymatically as well as non-enzymatically by reaction with glutathione. Sodium nitroprusside is used in treatment of emergency hypertension. And unlike GTN, no tolerance is developed even with continuous infusion. The peptides or signal molecules having direct effect on blood vessels are called as vasoactive peptides. They are divided into vasoconstrictor and vasodilator groups. The vasoconstrictor peptides include angiotensin II, vasopressin or antidiuretic hormone, endothelins, neuropeptide Y and urotensin. While the vasodilator peptides are kinins like bradykinin, natriuretic peptides like atrial or brain natriuretic peptide, vasoactive intestinal peptide, substance P, calcitonin gene-related peptide, and adrenomedullin. From vasoconstrictor peptides, we have learned angiotensin II in renin-angiotensin system and vasopressin in antidiuretics. So now we will learn endothelins. Endothelins are of three subtypes: endothelin 1, endothelin 2 and endothelin 3. Vascular endothelium mainly produces endothelin 1 and the plasma half-life of endothelins is only 4 to 7 minutes. There are two types of endothelin receptors, ETA and ETB. ETA receptors have higher affinity for endothelin 1 and ETA receptors are mainly expressed in vascular smooth muscles, while in vascular endothelium only ETB receptors are expressed. Both ETA and ETB are G protein coupled receptors and their activation leads to phospholipase C, IP3-DAG pathway, calcium release and contraction of smooth muscle as shown in figure. In endothelial cells, endothelin 1 is synthesized first as a larger peptide called as pre-pro-endothelin 1. Pre-pro-endothelin 1 synthesis is increased by transforming growth factor beta, interleukin 1 and other vasoconstrictor peptides like angiotensin 2 and vasopressin. At the opposite side, vasodilators like nitric oxide, prostacyclin and atrial natriuretic peptide inhibit synthesis of pre-pro-endothelin 1. Pre-pro-endothelin 1 is then broken down to big endothelin 1, which is converted to endothelin 1 with help of endothelin converting enzyme. This is similar to angiotensin, in which angiotensin 1 is converted to angiotensin 2 with help of ACE. Now in endothelial cells, this synthesized endothelin 1 acts as autocrine signal molecule, means on same endothelial cell, and also as paracrine signal molecule, means on adjacent smooth muscle cell. As autocrine signal molecule, endothelin 1 acts on ETB receptors present on endothelial cell to cause indirect vasodilatation, because ETB receptor activation stimulates release of nitric oxide and prostacyclin, which are smooth muscle relaxants, via cyclic GMP and cyclic AMP respectively. While as paracrine signal molecule, endothelin 1 diffuses to adjacent smooth muscle cell where it acts mainly on ETA receptors to cause sustained direct vasoconstriction by contracting smooth muscle. Because ETA receptor stimulation activates phospholipase C inositol triphosphate and diacyl glycerol pathway. ETA receptors also increases calcium influx through calcium channels, which leads to smooth muscle contraction. Endothelin's prominent action is obviously sustained vasoconstriction. But when endothelin 1 is injected intravenously, it causes brief fall in blood pressure because of release of nitric oxide and prostacyclin from endothelium, followed by sustained rise in blood pressure as direct action on vascular smooth muscle. Endothelin 1 also increases heart rate and cardiac contractions. Salt and water retention occurs through aldosterone release from adrenal gland. In respiratory system, it causes bronchoconstriction and raises pulmonary artery pressure. At long term, endothelin 1 stimulates vascular and cardiac tissue hyperplasia. And overproduction of endothelin is involved in various conditions like pulmonary artery hypertension, essential hypertension, coronary artery disease, atherosclerosis, asthma, and chronic kidney disease. Coming to endothelin receptor antagonists, they are available either as dual ETA and B receptor antagonist, including bosentan and macitentan, or as selective ETA receptor antagonist, including ambrisentan. Sitaxtentan, a selective ETA receptor blocker, has been withdrawn from the market because of fatal hepatotoxicity. The only approved therapeutic use of endothelin receptor antagonists is pulmonary artery hypertension. However, they are also being evaluated for congestive heart failure. Endothelin receptor antagonists are orally effective, well tolerated, newer, and one of the first line drugs for treatment of pulmonary artery hypertension. They decrease pulmonary artery pressure, improve hemodynamics, and increase exercise capacity. Adverse effects of endothelin receptor antagonists: elevation of hepatic transaminase levels, commonly with bosentan, so that while bosentan is prescribed, monthly liver function test should be monitored, and it is contraindicated in liver disease. Bosentan is also a microsomal enzyme inducer, and due to that, it can cause drug-drug interactions. Peripheral edema occurs mainly with ambrisentan. Mild anemia with all ERAs is due to fluid retention and consequent hemodilution. All ERAs are contraindicated during pregnancy as found teratogenic in animal studies. The other side effects include headache, nasal congestion, flushing, and palpitation. The other group of drugs for treatment of pulmonary artery hypertension are phosphodiesterase 5 inhibitors like sildenafil and tadalafil, which are orally active and drug of choice at present. They also can be combined with ERAs, mainly tadalafil with ambrisentan. Another group is prostacyclin analog like epoprostenol, but it has to be given parenterally by intravenous infusion.